Special populations in exercise and sports. A spinal cord injury is defined as a lesion to the neural elements within the spinal canal. This could be traumatic, or it could be congenital, which means the individual is born with it. The most common cause of traumatic spinal cord injury is a motor vehicle accident, representing approximately 42% of all injuries in the United States. The majority of people living with spinal cord injury are male, approximately 82%. There are several types of spinal cord injury. It could either be complete or an incomplete spinal cord injury, which we'll talk about. Common sports for athletes with spinal cord injuries include track and field, basketball, and rugby. Athletes with spinal cord injuries utilize wheelchairs specifically designed for their chosen sport, with the exception being swimming. Spinal cord injuries are classified based on the neurological levels of impairment. They are classified as either A, B, C, D, or E. Spinal cord injury A is complete. There is no motor or sensory function in the lowest sacral segment, S4 to S5. Spinal cord injury B is a sensory incomplete, which means some sensory function occurs below the neurological level and in S4 and S5. Spinal cord injury C is motor incomplete. There is voluntary anal sphincter contraction with some motor function to 3 levels below the motor level of the injury, but most of the key muscles are weak. Spinal cord injury D is motor incomplete, the same as C, with the exception that most of the key muscles are fairly strong. And spinal cord injury E is normal, although hyperreflexia may be present. Normal sensory and motor recovery are exhibited. The classifications of incomplete spinal cord injuries. Tetraplegia is an impairment of motor and sensory function of the arms, trunk, leg, and pelvic organs. Incomplete spinal cord injury involves some degree of sensory and motor function below the level of the injury. We could have thoracic paraplegia or lumbar paraplegia. An anterior cord syndrome results in an impaired ability to correctly detect temperature, touch, and pain sensations below the point of injury. Eventually, some movement may be later recovered. We could also have central cord syndrome, which results in the loss of motor function in the arms, but some leg movement is retained and some recovery is possible. Posterior cord syndrome, the patient will retain good muscle power, pain, and temperature sensation but have poor coordination. Brown-Séquard syndrome results in opposing bilateral function because the damage is to the lateral aspect of the spinal cord. The patient will have unilateral impaired loss of movement, but preserved sensation on one side of the body and preserved movement and loss of sensation on the other side of the body. Cauda equina lesion results in a loss of full or partial sensation below L1 and L2. It is possible that function may eventually be restored. We could also have thoracic paraplegia. The majority of individuals with spinal cord injury that participate in recreational activity have thoracic paraplegia. They have full motor and sensory function in the upper extremity. Lumbar spine paraplegia is full motor and sensory function of the torso and the upper extremities. There are varying degrees of sensory and motor deficit of the lower extremities. Several complications can occur with spinal cord injuries. Urinary tract infections, or UTIs, are common among individuals with spinal cord injury and may be life-threatening if not recognized early and treated. The bacteria may be introduced during urinary tract catheterization. Elite athletes competing with spinal cord injury catheterization an average of 4 times a day and often reuse the same catheter multiple times, increasing their risk of developing UTIs. Neurogenic bowel occurs due to impaired sphincter muscle control and disruption of normal ambulation, impacting normal bowel motility. Pressure sores. The skin begins to break down after about 15 minutes of constant pressure, with the first sign being redness. Tissues break down, occurring in 4 stages. If left untreated, bed sores can be life-threatening as the infection may spread to the vital organs. Other causes of bed sores include prolonged exposure to wet skin from sweat, stool or urine, and bruises, burns, or scrapes that go untreated. Deep vein thrombosis or blood clots are high risk due to the lack of muscle contraction and decreased blood flow, especially during the acute phase of an injury and when bedridden. Blood clots form most often in the veins of the thighs and lower leg. If the clot becomes dislodged, it may travel through the body to the lungs, resulting in a pulmonary embolism. Respiratory considerations. These individuals are at risk for developing a pulmonary embolism secondary to a DVT. Pneumonia is also common. Autonomic dysreflexia is a rare but dangerous condition in wheelchair athletes that is commonly triggered by an obstructed bowel or bladder, which disturbs the regulation of blood pressure and heart rate. Spastic muscles. Approximately 80% of people who have suffered spinal cord injury develop muscle spasticity. Acute prolonged spasmodic episodes may be triggered by superficial cutaneous stimulation, such as exposure to heat or cold, and bladder distension. Episodes may be so violent and forceful that the patient may be thrown out of his or her wheelchair or could possibly fracture bones. There may also be a diminished, absence, or altered pain response. The pain experienced by individuals with spinal cord injury includes neurogenic, musculoskeletal, visceral, or referred and chronic pain. Spinal cord injuries have an effect on exercise, such as sympathetic decentralization, which can result in venous pooling, orthostatic and exercise hypotension, edema, and thermoregulation issues. Most adaptations during exercise with spinal cord injured individuals are more peripheral in nature, such as the increased size, strength, endurance, aerobic power, anaerobic power, blood flow, enzymes, and glycogen, as opposed to central adaptations, such as an increase in stroke volume, cardiac output, blood volume, oxygen delivery, and high-density lipoprotein cholesterol. Motor dysfunction can lead to muscle atrophy and deterioration, flaccid or spastic paralysis, cardiovascular deconditioning, and osteoporosis. Many individuals with spinal cord injury will have pronounced orthostatic and post-exercise hypotension. We need to examine the injury diagnosis, treatment, and rehabilitation considerations. These individuals are susceptible to burning of the skin. They may have motor dysfunction, again that hypotension, especially post-exercise, and thermoregulatory system issues, especially following exercise. Individuals with spinal cord injuries, spina bifida, post-polio paralysis, and/or amputations may utilize a wheelchair to participate in many exercise and sports-related activities, including track, road racing, basketball, tennis, field events, bowling, archery, slalom skiing, table tennis, swimming, and many other sports and activities. Common injuries to wheelchair athletes include muscular injuries, sprains, strains, inflammation, blisters, lacerations, abrasions, skin cuts, pressure sores, arthritis and joint disorders, fractures, hand weakness, or numbness. We also have to consider the environment. Environmental considerations are more likely to occur in wheelchair athletes, including heat illness and hypothermia. When nerve disruption occurs, there could be a decrease in sweating, which may affect their thermal regulation. Bladder dysfunction may occur with individuals who have neurogenic bladder, including conditions such as bladder infection, incomplete bladder emptying, bladder stones, and a bladder obstruction. It is important that wheelchair athletes drink a large amount of fluids to keep the bladder healthy. Orthostatic hypotension is caused by prolonged sitting or sudden and rapid shifts in body position. This results from the inability of the sympathetic nervous system to adjust to rapid changes in body position. Individuals with orthostatic hypotension will feel lightheaded or faint. Many wheelchair athletes take a variety of medications for infection, abnormal muscle tone, seizures, and other neurological conditions, so it is important to be alert for drug reactions. We need to be concerned and care for the safety of our wheelchair athletes just the same as every other athlete we care for. The most common issue for athletes with amputation is irritation at the junction of the amputated limb and the prosthetic device. This is more of an issue with the lower extremity because of weight-bearing forces. Due to the lack of sensation, initial irritation may go unnoticed. Look for redness, skin irritation, and occasional swelling. Infections can lead to potentially serious complications. Cerebral palsy involves uncontrolled muscle spasticity, which can range from mild to severe. Because of the increased load on the musculotendinous units as a result of the continuous muscle contractions and limited joint range of motion, muscle strains are common injuries for individuals who are diagnosed with cerebral palsy. Sports participation with visual impairments have issues with unseen barriers. Not being able to see can make navigating road surface conditions, walls, curbs, and other competitors as the person lacks these visual cues that others take for granted. Marla Runyon was a legally blind marathon runner. Marla Runyon has won 3 national championships in the women's 5,000 meters. Most notably, she became the first legally blind athlete to participate in the Olympics at the 2000 Sydney Olympics, where she placed 8th in the 1,500-meter race, the highest finish by any American woman at that event. Eric Y. Hennemeyer became the first legally blind person to reach the summit of Mount Everest, an achievement which was profiled in Time magazine and covered in his autobiography, Touch the Top of the World, A Blind Man's Journey to Climb Further Than the Eye Can See. Eric maintains an active lifestyle as an acrobat skydiver, long-distance biker, marathon runner, skier, mountaineer, ice climber, and rock climber. Trish Hanzorn was a Paralympic Hall of Fame swimmer. Trish Hanzorn was a U.S. swimmer who had been blind since birth. Most notably, she has won 55 medals, 41 gold, 9 silver, and 5 bronze, making her the most successful athlete in the history of the Paralympic Games. Craig McFarlane lost his vision at age 2.5 during a welding accident. His athletic instinct kicked in at an early age, and by age 8 he had won his first wrestling tournament. Inspired by this achievement, Craig went on to compete in a wide variety of sports and earned 103 gold medals in wrestling, track and field, swimming, snow skiing, water skiing, and golfing. Craig Acucoin was always active in sports growing up. Upon losing his sight at age 16, he turned to sports as a way to regain his confidence and independence. Craig has now participated in 7 triathlons and has completed a bicycle trek across Canada. These individuals may have trouble with unseen barriers, so we may use a spotter or other resources to help these individuals. Visually impaired athletes are at an increased risk for lower leg injuries. It is estimated that 60% of adults aged 65 and older participate in physical activity. The aging process plays a major role in skeletal and neuromuscular function. Muscular injuries can occur more frequently in the older adult. Aging decreases the density of collagen, which lowers tissue elasticity. The more active we are as we age, the better the aging process. So get out there, get moving, and stay moving.